My topic today is a cleft lip and cleft palate for the pediatrician. As said, I work as a consultant pediatrician. I have no commercial interest to disclose, but I volunteer for Operation Smile as pediatrician, and that's where my interest in cleft lip and palate comes also. Objective for this talk is sharing the understanding of the holistic nature of care for these patients, problems that are ignored and then can cause serious problems later on. And I would like to start by talking about life before, in between, and after surgeries. We usually try and correct these problems early on, but it's not always possible. But parents' question always is, does this occur often? There's a different prevalence in varied populations. In Asia, it's about 1 in 5,000 births. Hispanic population similar, but Caucasian is a little bit less, 1 in 750. And African American, for instance, only 1 in 1,000 or 1,500 births. We notice from this that it is relatively common, and it is more common if you have first-degree relative with cleft lip or cleft palate, and that increases the percentage. If you have a first-degree relatives too, then it increases the risk tenfold. How do we find out about this? Usually it's a shock at delivery, but parents always see, should they have seen it before birth? Ultrasound nowadays is an excellent tool, but as you can see in this picture, you need a 3D dimensional ultrasound, and only in that, if you get the right plane for the review, you can see the cleft lip. Cleft palate is far more difficult to detect on ultrasound because it's obviously not visible on the outside region. The left-sided cleft lip is much more common than right side, and bilateral is less common of the 3 options for cleft lip. Cleft lip, for some reason, is more common in males, and cleft palate can be at hard palate, soft palate, or submucosal palate. So it's different levels. Cleft lip or palate is a disrupted development. It happens early on in pregnancy. So there is, usually I tell the parents, there's nothing they could have or should have or would have done that would have made the difference, because it already happened before the mother actually knew that she was pregnant. Usually around 5 to 6 weeks of embryonal development, or very soon thereafter, the disruption happens. There is a strong association with syndromes, and complex combinations of findings always give us a suspicion of syndromic features. 10 to 15% with cleft lip, and if there's also a cleft palate, then it increases up to 50%. Here we can see why the cleft lip and palate develops. There is a very complex system. What needs to stimulate what, so that the complete palate and lip development happens. So it's not an easy sequence to happen, and therefore it gets disrupted very easily. Genetics does play a part, but environmental exposure is more often the reason. The reasons are smoking, folate deficiency in mother before the pregnancy even starts, retinoic acid, anti-epileptic drugs, steroids, and drug abuse are the most common environmental reasons for cleft lip syndrome. genetics evaluation is utmostly important, especially with the more complex findings. And congenital malformations can be isolated, but when they present in a combination, the genetics evaluation for these patients is very important part of the discussion at some point. Pierre-Robin sequence, I took this as an example. Here we see a child with clearly not very developed lower jaw, and therefore he ran into trouble in early after birth. This came as a surprise for the parents. They are non-consanguineous parents, have one healthy child, and this pregnancy went on well. And when the baby was born, he could not breathe. He had to have ventilation initially and then oxygen support to figure out how to breathe. And this is usually the lower jaw development is arrested or not fully ongoing. Therefore, the tongue gets pushed back into the mouth, and that results in the palate not being able to join as there is no space. And as happens often with these babies, cleft palate is formed, and the combination of this symptomatology ends in breathing and feeding problems. With these babies, cup feeding often helps a little bit to figure out how the baby can swallow and what can happen, because mother can watch the baby's face and position is easily maintained upright or sidewise or tilting to the side, and therefore we can see what the baby can do. Obviously, as you can see in this picture also, the mainstay of the feeding happens with the nasogastric tube, because we can't practice more than the baby can tolerate. If the practice takes longer than 30 minutes, the baby actually uses more energy into the feeding than he gains from the feeding. So it's really important to continue, but make it safe and give the baby also nutrition for growth and development. Here you can see how this baby then progressed into feeding. When we figured out position, he was maintained on an upright position, but only on the sideways. At this point, his breathing had already improved and he actually tolerated being on his supine position, whereas in the beginning, he could only be maintained on sidewise lying position or sometimes on his prone position. But here you can see he's learning to feed by himself, and he has a safe swallow with no signs of aspiration. Problems. Cleft lip is more of an aesthetic problem. It's seen as a visual changed appearance, but it causes school absence and not able to work because you're shy of how you look like. And it also exposes the child to bullying and not able to have the quality of life. And unfortunately, adults bully these babies as much as children do. And quite often, for instance, I've heard from my patients that teachers have no understanding to help these children in school life. Cleft palate obviously is not as visible, but it causes breathing problems, feeding and nutritional problems. Speech is very often unclear and not able to be understood, and not able to earn a living as you grow into adulthood. Parents need to understand that operations have an optimal timing. We cannot correct immediately something because the structures are not yet ready for it. So the parents need to be educated to how to keep the mucosa healthy and how to help the baby in the early life to manage. Cleaning the mouth is important, and parents need to get used to handling it so that it's safe, gentle, but effective, so that the mouth hygiene is maintained throughout the early life. While we're waiting for the surgery, we can do something. We can help the baby, for instance, by taping to get a better position for feeding. And that often is used for small babies with various types of cleft lip problems. Cleft lip repair is not just putting the parts together. We aim to find a balanced correction so that we can match the muscle from both sides layer by layer, so it's functionally correct. And here you can see another way of correcting. The muscle layers need to match so that the muscle works properly. The skin needs to look normal after the healing process is completed, and all layers need to be in matching positions to have a balanced result. Normal palatal function is a very complicated set of muscles and bony structures to work together to allow for swallowing, speech, and they need to be functioning together. Therefore, operations need to happen usually a little bit later, and the pediatrician helps in this period with the breathing difficulties, mostly with cleft palate babies. Feeding difficulties, breastfeeding is sometimes possible, especially with cleft lip patients, and needs to be encouraged. But if breastfeeding is not possible, then special bottles and eating solid food at the time when solid food needs to be introduced. Correct nutrition is important, right food for the right age, and how to manage if surgery is delayed. Because for the surgeries to go on smoothly, we need to practice all the muscles that are in the mouth so that they are ready to function after the operation. And also sometimes after first surgeries, there can be a fistula development, and we need to help parents manage those issues. Of course, pediatrician also needs to make sure that the child is ready for surgery. There's no infections at the time of surgery, and guiding into speech therapy, dental services, and so on, following the care. Going into the surgery, nutrition is important because, of course, surgery requires a recovery period, and the child needs to be in good nutritional condition to be able to go through that. We check for infections and no other health problems that affect the anesthesia or surgery. And discuss with the parents so that they know what to expect. That, of course, surgery requires recovery. There is issues that we need to deal with, and the parents are an important part of this recovery process. During the surgery, we advise the parents how to practice syringe feeding, because quite often after surgery, this is important way of giving enough fluids for the baby, as obviously with the cleft palate especially, we don't encourage using bottle feeding after the post-surgical phase. And often it's not a problem, but if the child wants to feed that way, but necessary for the recovery period, and it is sort of important to discuss this very early on before the surgery comes, because obviously you can't change a feeding practice overnight if you don't do it before. Child should be weaned off the bottle if at all possible, or at least used to receiving some fluids with either spoon, syringe for the days after surgery. Nutritional optimization means also starting other foods. If the surgery, for instance, cleft palate happens at 9 months, by that time, the baby should already be used to having soft food so that he can then continue that after the recovery period. Learning to eat soft food is really, really important. And unfortunately, quite a few parents get advised that they should just continue milk feeding forever, which then delays the recovery after the surgery. After surgery, We of course need to take care of pain relief, which needs to be effective so that the child can continue drinking after the surgery and after recovery from the operation. And it is really important mainstay. We usually try and prevent the small children touching their face, and you can see here the so-called nunus, which are kept on the child's arms to keep them away from the face for a certain period after the surgery. Care of the wound is important to teach the parent how to look after it. Nowadays, it's much easier because we usually use the glue on the cleft lip, for instance, so there's not much that needs to be done except keep the area clean. Ongoing nutrition is important for cleft palate babies. They need to be on liquid diet for a while, so parents need to understand what liquid diet is and what it is not. First surgery is not usually the last surgery. Additional surgeries are fistula correction, dental procedures, bony reconstructions, jaw, palate, and dental positioning. And optimal time for lip surgery is around 3 to 6 months. Optimal time for palate surgery is from 6 to 9 months. And those are sort of optional, but surgery correction can be made at any age because quite often if the parents cannot afford the surgeries get delayed longer. And cleft surgeries are never cosmetic surgeries. They are always corrective surgeries, and this needs to be made clear to the insurance companies who need to cover these procedures. Additionally, nutritional follow-up is really important all the time. Right time for any feeding, right diet for any child. Dental care and follow-up and continued requirement, as of course if there's a cleft palate, sometimes the gum line is distorted, and even later on the dental follow-up is important. Speech therapy.
Sorry, Dr. Liz, don't
Thank you. Yeah, I'm almost finished. Speech therapy needs a skilled therapist who understands the problems and can actually help the child with this. Social support for the families and connecting with other people that have similar problems. Educational support, education for schools, teachers, and parents. And important is the holistic supportive care. A pediatrician needs to follow through with supporting families to cope, encouraging the child to achieve potential development, make realistic plans. And these are the sentences from some of our patients. I can go to school after surgery. I can marry someone after surgery. I can speak, so now I can work or go to school and people will understand my words. These are the hopeful and delightful results post-surgical care. Thank you.
Thank you very much, Dr. Eeva-Liisa, for the informative presentation. We do have a few questions here. The first question is asked whether the cleft palate will affect the cognitive function for babies.
Cleft palate as such doesn't affect the cognitive function unless there's something else coinciding with it, but it does quite often, if we do not have the right supportive care, it makes difficulties in learning because the child needs to be able to speak. First of all, be able to speak, then learn to speak and learn to use the voice and sounds properly. So it needs a little bit of assistance, but cognition has usually nothing to do with cleft palate.
Okay, and another question, if you can explain please how to introduce the nasogastric tube to this disrupted anatomy.
Nasogastric tube is that's an excellent question actually, because babies that have cleft palate quite often need a special consideration when you are inserting the nasogastric tube. These babies do not easily tolerate lying supine while this procedure is happening. So it's quite often I found that if the position, the baby side lying positions, making sure that the line with the head and the body is straight, the passing of the nasogastric tube is easier and much more comfortable for the child, and doesn't consist any crying or any episodes like that. Other than that, the nasogastric tube is inserted as the usual. You measure the distance between the nose and the ear and to the stenoid schifoid, and you just insert the appropriate length and test the positional situation once insertion is happened.
One more question, whether there is an increased risk between cleft palate and lip and a soft tissue tumor, possibly in the future?
No, there's been not any studies that show that there is any increased risk for any malignancy or maldevelopment in that direction. But of course, depending on the timing of the surgery and the extent of the cleft palate, how well we can match the muscle layer, the bony layer, and the mucosal layer into the mouth depends on how good the correction happens to be.
And another question, whether if surgery was not done on a cleft lip, any problem will happen because some families doesn't have the money to really proceed with that surgery.
Exactly. Well, that's where Operation Smile helps families, for instance, who cannot afford the surgery. As I mentioned on the lecture, the corrective surgery can be done at any age. With the Operation Smile missions, I have seen surgery done on a 49-year-old woman who could not have the surgery done before, and on any age, basically. I've seen adolescents, young children, older children, adult people, and the age as such is not, of course, the effectiveness of the surgery. If the tissues are very shrunken, it becomes a little bit more of a surgical problem, but surgeries can be done at any age and should be done when it's possible.
The last question is that either frequency, what's the frequency rate if a parent has or one kid has cleft palate? So
if they already have, if they already have one child of cleft lip or cleft palate, the risk is a little bit higher. It's increased 2 to 5%. But if they have, if for instance we have had mothers who have cleft lip, then the risk is, or in the family other members have cleft lip or cleft palate, then the risk increases to 10 to 15%. So it does. So we see that there is a clear genetic connection sometimes, but some of them are just spontaneous changes that happen during that particular pregnancy.
Okay, thank you very much, Dr. Eeva-Liisa, for the nice talk.
Thank you.
And hope we meet you some other time in another conference.